All right, guys, we're going to get started. Today is our week 7 presentation. And today we are going to be doing filler recap. So let me go ahead and do a quick screen share. So today is week 7, and we are going to be going over a filler recap of everything that we went over in training. We're going to see if anyone has any questions about general MFL operations, and then also any questions about AR review as well. And then we have our marketing ideas and homework for the week. Okay, so when you're looking at filler, the most important thing that everyone needs to know is that you need to have an idea of the basic anatomy of the vascular of the vessels underneath the skin. So the big kind of heavy hitters are starting from the external carotid. You're going to drive all the way up into the neck, and then you're going to come out of a foramen right here, right in front of the masseter, and this is going to be your facial artery. Your facial artery is then going to travel up towards your mid-face, and from here, it's going to dive into the lower lip, and that is the inferior labial artery, and then feeding the top lip is the superior labial artery. As this travels up, this is going to turn into the angular artery that runs directly next to the nose and continue on up into the forehead to become the supraorbital or supratrochlear artery as well. And then from there, it's going to dive deep into the skull, coming out another foramen, which is directly below the pupil, and that is going to be the infraorbital artery. Those are kind of the big heavy hitters. Obviously, there are several more arteries that everyone needs to be aware of, but those are the ones that you are primarily going to be working with and need to stay away from whenever you are injecting filler. So we are also going to pull up my filler presentation. So again, you have your external carotid coming on up. This is your facial artery right here. Diving down deep into the lip is your inferior, and then you have your superior labial artery. Continue on up. This is your angular, all the way up to your supratrochlear, and then you have your supraorbital as well over here. Then this dives down deep into the face, coming out of foramen, which is directly below the pupil. This is your infraorbital. And then your external carotid actually continues on up and travels in front of the ear, and then it will kind of jet across the face, and this is the transverse facial artery, which feeds the majority of the mid-face. So whenever you're doing filler, you need to be aware of what layer of the skin or a layer of the face you're going to be in. There are a total of 5 different layers. Layer 1 is going to be the skin. Layer 2 is going to be the sub-Q area. Layer 3 is going to be where the muscles are. And then layer 4 is going to be the retaining ligaments. And then 5 is going to be the periosteum. So whenever you are choosing a product, you need to select an appropriate G prime. Remember that G prime is the thickness or the viscosity of the filler. The higher the G prime, the thicker the filler. These are the primary fat pads of the face. As we age, they start to separate and disintegrate. They're kind of like continents. And again, this starts to happen at the age of 35. And here in a little bit, you can see how the face ages from 35 all the way to 55. At 55, the patient will have pretty profound volume loss. Sorry, I gotta drink some water. Okay, so what are dermal fillers? It is basically a gel-like substance that is injected beneath the skin, and it helps restore volume, smooth out lines, decrease deep lines and wrinkles, and enhance facial contours. Typically, with a hyaluronic acid fillers, it comes with 1 native syringe and then 2 native needles. These are all the different things that filler can do, but really there is no limitation of where you can put filler. But for aesthetic purposes, for my face lady, we primarily stick to the face and to the hands. So these are the different umbrella fillers. When we say the term filler, it means the HA fillers. You can have the Radiesse, which is the calcium fillers, and then you have the Sculptra, which is the polyl-lactic filler. The Radiesse and Sculptra, they're not like a gel. It is more of like laying seeds that help promote the body to produce its own natural collagen. So with these particular type of quote unquote fillers, it is a little bit of a different recovery and how the patient experiences their final results. Where hyaluronic acid fillers, the patient will experience results immediately. And Radiesse and Sculptra, it does take anywhere between 2 to 6 months for those seeds to grow and the patient to see their full results. Again, talking about G prime. G prime is going to be the thickness or the viscosity of the filler. The higher the G prime, the stiffer the product. So if you have a really high G prime product like Restylane Lift, it's the highest G prime product out in the US market. That has to be laid at least in layer 4. It has to be very close to the periosteum because it is so thick. It almost acts like a concrete gel. And so you want to make sure that there's enough tissue sitting on top of it so it doesn't look lumpy or bumpy underneath the patient's skin. This is that G prime chart that we hand out in training. So you have Restylane Lift. Again, Restylane Lift is one of the highest G prime products out there. And then on the total opposite, you have Restylane Refine, which is the lowest G prime product. So this product is very much so like water. And whenever you put it into the patient's kind of layer 1 or layer 2, it really does a great job with those kind of perioral fine lines and wrinkles. It's a great product. So in training, we kind of talk about some of our kind of the favorite go-to fillers for some of the different trainers. So for my low G prime products, these are going to be the kind of the top 3 that we like. Reminder that MFL no longer carries the Juvederm products. The medium G prime, this is going to be for nasolabial fold and lips. And then you have the high G prime products. These are going to be primarily for deep nasolabial fold and cheek, with the exception of Restylane Silk. We kind of talk about Restylane Silk a little bit in training. Restylane Silk, while it does have a really high G prime product, the particle size is very, very small. So it cannot be laid very deep. It does have to be laid a little bit more superficial. But Restylane Silk is also very hydrophilic, meaning loves water. So it does have a pretty profound swelling effect. So whenever you're doing your physical exam and interview, these are the medical questions that you want to make sure that you're asking all of your patients. You want to ask them if they have any allergies or sensitivities specifically to lidocaine, because lidocaine is impregnated in all of the products. If you do have a patient who is allergic to lidocaine, please reach out to corporate and then we can request to get a lidocaine-free option. Not all of the fillers do come lidocaine-free, so just know that. You also want to ask if the patient has gone under any type of cosmetic procedures or surgeries. You really want to know what's going on underneath the skin. If the patient has a chin implant or if they have silicone that they've had injected, you need to know exactly what is going on. And sometimes the patient may not know what was injected. Some people get things done in other countries, and unfortunately, we don't have a good history of what was done. You also want to ask if they're taking any type of medications or supplements. Ask if they have a history of cold sores. If they do, and you're going to be doing anything around the perioral area, you need to call in or have your telemedicine provider call in Valtrex 2 grams PO BID times 1 day. You also need to ask if the patient is pregnant or breastfeeding. And then finally, any autoimmune disorders. Now, if they do have an autoimmune disorder, this does not mean that they cannot get filler. You do just have to do a little bit more education because the patient has an autoimmune disorder. They have a tendency to kind of fight that filler after you inject it. So that's just a conversation you have with your patient. For the physical exam, you want to look at the skin quality and texture, make sure the patient doesn't have any open wounds. You also want to look at the facial symmetry. Everyone has a little bit asymmetry to their face, especially if they sleep on one side of their face. One side will be flatter compared to the other. And then also you want to pay attention to the wrinkles and to the volume loss. And you want to look at the bone structure and the contour. And then finally, you want to assess the vascular health. A lot of times when I am looking at a patient and I am doing my assessment, I'm going to be kind of feeling around and I'll actually feel some of their pulses. I'll feel for their facial artery if I'm going to be doing some jaw work. If I'm going to be doing their lips, then I'm going to be feeling for that inferior and superior labial artery, just so I have an idea of where that artery is inside of that lip. This is going to be that pre-treatment checklist that you're going to go over with your patient. Always have them try to avoid NSAIDs a couple of days before. They also want to avoid any high doses of vitamin E, fish oil, or anything like that. No alcohol for 24 hours before. Same thing with coffee and tea and caffeinated beverages. Anything that's going to have caffeine in it is going to have a tendency to cause the patient to bleed a little bit more. So I usually try to have them avoid it the morning of. Now, this is not always feasible, but it is definitely a conversation if you can talk to your patient before your procedure. You do want to make sure that they are not having any vaccines at least 6 weeks before or after they get filler. And again, because the patient is trying to get a vaccine and the desired immune response from it, we don't want to do anything that's going to blunt that immune response. So 6 weeks before or after. And then no dental procedures 2 weeks before or after. And this is more just because of swelling. So if the patient is supposed to have a crown put in, ideally they need to wait 2 weeks before or after. The patient is going to have some swelling before. And so that would make it very difficult for you to do a true assessment on the patient. And then if they wanted to get it done after, the patient is still going to be swollen from their aesthetic procedure. And the dentist is going to be putting some hardware in the mouth that could potentially move the filler around. And then again, if the patient is getting anything done around the perioral area, make sure you pre-treat for herpetic lesions. These are going to be the contraindications that are an absolute no-go. Any type of blood-thinning medicines like warfarin, Lovenox, Eliquis, Xarelto, those are an absolute no-go. Patient cannot get filler. If they have an active infection, if they have an active cold sore, or they have some active acne going on where you want to inject, if the patient is pregnant or breastfeeding, or again, allergic to lidocaine. So these are going to be the no-goes. These patients are not allowed to receive filler. All right, let's talk about complications. So these are the common side effects that I tell all of my patients. Bleeding and bruising, swelling, lumps and bumps are normal and expected up to 2 weeks. Tenderness, and of course, if you do not pre-treat for a herpetic outbreak, a patient can get an active cold sore. So I really like this graphic because it really kind of talks about how the patient's journey is going to be after they have their lips injected. So day 1, they're going to get their filler, and then that night, including into the next day, the patient's going to have a lot of swelling. And this is usually when you start to hear patients starting to freak out. They usually will send you a text or send you an email. And this is where you're just going to reassure the patient, let them know that this is normal and expected. And then over the next 14 days, they're going to progress to their final results. So lumpy and bumpiness, normal and expected. Patient will be having some bruising. If they don't, you can be their best friend, but really do a lot of education with your patients before you inject their filler. That way they kind of know what to expect. And that will alleviate some of the questions and concerns that you can get from your patients. So these are going to be the major complications. The first one is going to be cellulitis, and this is a little bit more than a pimple. This is going to be more of a profound infection that has gone into the tissue, and it is true cellulitis that has to be treated with antibiotics. And then we have vascular occlusions, which we'll go into here in a little bit, and then allergic reactions and hypersensitivity, and then finally delayed onset granulomas. So the stages of a vascular occlusion, each stage is around 12 hours. That very first stage is going to be blanching. Stage 2 is going to be that reticular lacy pattern. You'll have some blanching along with some erythema present. Stage 3, you're going to be having some vesicles. This is when a lot of people think the patient is simply having a herpetic outbreak. Stage 4 is you're going to start have that initial skin breakdown, and then stage 5 is full thickness necrosis. So again, on average, every stage is going to be around 12 hours or so. And there are 2 types of vascular occlusions. The first one is going to be an interarterial occlusion. This is while you are injecting the patient will automatically have the tissue will turn white, and it will be very obvious the patient is having a VO. You can also have a compression occlusion. This can occur while you are injecting, but it can also occur up to 24 hours after you were injecting. And this can be because 1, the filler was laid too close to a vessel and it's compressing the vessel, or 2, the inflammatory impact that the patient is having is compressing the vessel as well. Regardless of the type of VO, you're going to be treating them the exact same way. So Hylenex is the antidote to HA fillers. It does work very quickly. Whenever you are injecting Hylenex, it does burn like fire. So just prep your patient for that. We never dilute our Hylenex, okay? If you are having an emergency situation, we do have to have hyper-concentrated Hylenex because we are trying to dissolve the filler that is causing the vascular occlusion. So we want to make sure that this is undiluted. Just prep your patient, hey, this is going to burn, but this is considered a medical emergency, and we have to do anything and everything we can to get the blood flow flowing again. What's something interesting about Hylenex is Hylenex if you are allergic to bees, then you can have a higher chance of having an allergic reaction. So if the patient does have an allergy to bees, like a true anaphylactic allergy to bees, you need to pre-treat the patient. Now, we used to do patch testing, but we no longer do that because true patch testing actually you have to wait 2 weeks in order to really do a true patch testing. The way that the aesthetic world was kind of doing their patch testing was actually incorrect. We were only waiting 15, 20 minutes and then we are injecting. And that actually can put you and your patient at increased risk, especially your license, because that is an incorrect way of doing patch testing. So here at MFL, we no longer do patch testing. If the patient says that they have an allergy to bees, then we will absolutely pre-treat them with some Benadryl and maybe some steroids. But as far as doing patch testing, that is no longer recommended. All right, this is our vascular occlusion protocol. So step 1 is going to be, you're going to stop injecting. Step 2 is going to be aggressive massage. A lot of times whenever you think you have a VO, you might just be a little too close and you might just have a small little compression VO, and aggressive massage can move that filler around so you can restore blood flow. You are then, if you do not get good blood flow back after massaging, you're going to flood that entire area with 1 vial of Hylenex that is undiluted. You are then going to massage again, and you're going to wait about 5 to 10 minutes. If you are still not getting good blood flow back, at that point, you're going to be attempting to cannulate that vessel with 1 more vial of Hylenex, and then you should be getting good blood flow if you do have good flashback. Again, you're going to try to cannulate that vessel. So let's say I'm injecting the lower lip and I accidentally hit that inferior labial artery. I'm going to try to go as lateral as possible to get a larger chunk of that vessel, cannulate that vessel, and then I'm going to be injecting that Hylenex so I can try to dissolve that Hylenex as quickly, or the filler as quickly as possible. You're then going to be doing some warm compresses. The patient will take 325 milligrams of aspirin, and antibiotics will be prescribed along with hyperbaric therapy. So as far as treating infections for cellulitis, these are our kind of 2 big go things that we go to. Steroids, we're going to be calling in some prednisone, 60 milligrams PO Q day times 3 days. And then this is the antibiotics that we choose from for cellulitis. Either it's going to be some type of augmentin, Bactrim, Keflex, or clindamycin. So the reason why we have this image up here is because bruises can look pretty scary. Sometimes people think that bruising is a sign of a vascular occlusion, but it is not. A sign of a vascular occlusion are going to be the 5 phases that we just discussed earlier. So this very first picture down here over on the left side, this is a vascular occlusion. This is going to be a stage 1 because you're just having blanching. This one up here on top, this is simply a bruise. And then next to it is also a bruise. The larger picture over on the right-hand side, this is going to be a vascular occlusion, and this is going to be a stage 2. This is what that reticular lacy pattern looks like. And then walking our way down on the bottom, you're going to see this is simply a bruise. You have bilateral bruising. None of the phases are present. And then this picture down here, this is a vascular occlusion, and this is stage 3 of a VO, and that's what the vesicles will look like. So for the retinal occlusion protocol, what we always kind of tell all of our injectors is how to avoid a retinal occlusion is going to be your best and safest bet. And that is by not injecting any type of noses or glabella. And also with every single injection, you're going to be aspirating. The biggest thing is that you are going to be taking the patient to the closest, highest level of care where ophthalmology is on call. We are not going to be having injectors do retrobulbar injections. That does have to be done by a specialist. So we always recommend taking the patient to the largest medical facility that has ophthalmology on call to optimize the patient's recovery. Hypersensitivity, what we're going to be calling in is we call 60 milligrams of prednisone PO Q day times 3 days. And this will help decrease some of that swelling and discomfort the patient is having after filler. So in training, we talk about biofilm. Biofilm essentially occurs because a bacteria was injected while you were in while you were injecting the filler. And what will happen is a film will form around that bacteria. And then as that filler starts to break down, the patient will form a tumor-like substance to protect the body from the bacteria. The three best ways to prevent a delayed onset granuloma is going to be hand hygiene, patient selection, and product selection. So for patient selection, you want to make sure that the patient doesn't have any type of autoimmune disorders. If they do, that's just an additional conversation you're going to be having with the patient. And then product selection. Some of the Vicross products do have a higher chance of causing these delayed onset granulomas from occurring. And these will occur 6 to 9 months after the patient has been injected. So there's no way for us to know if it's going to occur. So the non-inflammatory nodules that occur with filler, it is generally seen post-injection, and it is usually because the product was laid too superficially. Sometimes the patient can also massage the area, or not enough massaging was done by the injector initially. So you do want to make sure that you are laying the filler in the correct plane and that you don't feel any lumpy and bumpiness right before that patient leaves. So for a non-inflammatory nodule, we usually have the patient wait that initial 2 weeks. If that nodule is still there, we will then have them massage twice a day for 2 weeks in that area. If that does not take care of it, then we will go in with some dedicated Hylenex and dissolve the nodule. So filler migration. This can occur for several reasons. It can occur if the product was laid in the wrong plane or the wrong area. It can also occur if the patient is massaging it and moving it around. Basically, when this occurs, you do have to dissolve and start over. After you dissolve something like this, you do have to wait at least 2 weeks for all of that inflammation to go down, and then you can refill the patient. Let's talk about safety. So for safety, you want to make sure that you are aspirating at least 6 seconds with every single injection. And that is 1,000, 2, 1,000, 3, 1,000, 4, 1,000, 5, 1,000, 6. This is just like wearing a seatbelt. Is it going to guarantee to keep you safe? Absolutely not, but it is a seatbelt. You also want to make sure that you know the anatomy of what's going on underneath the skin in general. And then you also want to watch for color change while you are injecting, and also slow, steady pressure. You don't want to blow a bunch of filler into the patient's face at one time, so go slow and steady. This is going to be the pre-procedure checklist. You want to make sure you do a good patient assessment. You want to have the patient sign all of their informed consents, do their procedure prep, and then finally you're going to be prepping the patient with sterilizing the patient's face as much as possible, and then marking exactly where you want to go. Post-op, you're going to be talking to your patient about no exercise for the next 24 hours. They can use a cool compress if needed. No makeup for the next 24 hours as well. No facials for 2 weeks, and they can use arnica for any bruising. All right, let's talk about how we inject. So these are the 4 areas that we talk about in training of how to inject. So for cheeks, these are the way that we taught to do cheek filler. And you're going to draw a line from the pupil straight down, lateral canthus straight down, and tip of the nose to the tip of the ear. You do want to move 1 centimeter up this line because that infraorbital artery is generally directly below the pupil. And you're going to put a total of 0.2 cc's of filler right into that first injection point. And then walking up that line where that line bifurcates, those 2 lines, 0.1, and then 1 centimeter up, 0.1. Again, this is a generalization. Every single patient is going to be different, but it just gives you a basic foundation of where to start, of how much to put into each injection point. For nasolabial fold, you can use a cannula. If you use a cannula, you're going to have your pilot hole way down here, and you're going to thread up into the patient's nasolabial fold, and you're going to lay 1 long 0.4 thread from the top all the way to the bottom. Again, very slow, steady pressure. If you do want to do the needle procedure, then you are going to do some cross hatching, and each line in general is going to be 0.01. And then also I like to do 0.1 of a paraform injection all the way down to the bone to really kind of help pop out that nasolabial fold. So for lips, we teach the line and fill method in training. And so how we do this is we kind of put dots all over the lip, and we're going to be lining this vermilion border, and then we're going to be filling it. On average, each little thread is 0.05 mLs, or if you do backfill it into an insulin syringe, it's a total of 2.5 units on the insulin syringe for each line. Again, this is a complete generalization, and every patient is going to be slightly different, and you do want to cater your procedure to your patient, but at least it can give you a foundation of where to start. For chin, you do want to make sure that you are staying within the normal masculine and female anatomy. To masculize the face, you do want to stay on the outer side of the oral commissures, because males tend to like a wider chin, where females, you want to stay on the inside of the nares. So from here, you can see that the patient has more of a narrowing chin compared to that masculine chin. Again, this is going to be all the way down to bone. You're going to make sure you aspirate. And for males, you can put up to 0.2, and for females, 0.1. You can repeat this as much as you need to get the full correction, but never put more than these amounts into each of these areas. All right. So that is typically what we go through with in our filler training. Are there any questions at all?
Does that training take place after launch?
I'm sorry?
Does that training take place after launch?
What do you mean?
Or going to additional training or to more classes?
Yeah. So you came through the oral exam, correct?
Correct.
Yeah. So that's actually the presentation that I do in really, I do it over like 6 hours. So it's a very much so condensed training that I just did. I just kind of go over it for people again that have gone through the class. After you do your launch party, you are more than welcome to come to any and all of our trainings that we offer and sit and listen in. We just ask that while you are there, that you do not inject, because those are for the injectors that are actually paying to inject patients. But we had 3 injectors come to our last training, just come and sit and listen in, because I just wanted to continue to learn. 2 of them actually have worked for the company for about a year or so, and after they left, they're like, oh my gosh, I learned something new every time I come. So any training that we have, you are more than welcome to come and sit and listen in. They typically go back and forth between Dallas and Houston. Remind me what city you are in. Are you in Virginia?
I would be Dallas.
Okay, perfect. So the next one is in November, and it's in Dallas. I would love for you to come if you want to come hang out with us.
All right, great.
Yeah. So do you have any questions about general MFL operations?
It's just until I guess do it all
Yeah,
at the launch, it would make more sense to me. That's just my learning style.
absolutely. I'm the same way.
It's a little bit harder.
Yes, absolutely. Until
And
you
being
actually get
all
into it.
online and not actually seeing anybody yet. That's
Yes.
different.
Yes. And then, after you have your launch party and you kind of go through everything, you have your onboarding specialist, you can reach out to me. We are always here to help you in any way we can.
It's awesome.
Yep.
Somebody
All right.
is helping me with my Facebook page this week.
Oh, wonderful. Wonderful. Is it Davina, or are you reaching internally, or is it an external?
It's a friend of mine. And also I noticed, I guess there was just some random posts, huge car accident, random car accident. It's just like, oh my God, I even have to change my password and haven't even done anything on my Facebook page.
What?
I just got notifications that, there's some posts on my page, about some huge
Oh my
car
God.
crash. I guess, I don't know, trying to get people to donate or something like that.
Oh, you got hacked. You got hacked, I hear.
Hacked, yes, that's the word.
Oh,
That's
okay.
why
I
I
was like,
don't like
wait,
social media.
what happened? Okay. All right. All right. So this week for the marketing homework, we asked that everyone does some type of Facebook or Instagram live or reel. And then you also want to post a before and after of some cheek filler. I do have that graphic for you. And then also we want you to do one type of education post this week of how the face ages. You can talk about the fat pads. You can talk about how at the age of 35, our body stops producing its own natural collagen, and it decreases as we age, which exacerbates that aging process. And then we want you to continue your social media following. And so we added 2 more great injectors and great accounts to follow. They do a lot of education, a lot of injecting. So there are 2 more people that I can kind of add that you can additionally learn from. So that is it for this week. Do you have any questions for me?
This will be posted on the Facebook site. I
Yes,
can
ma'am. Yep.
print it out. Okay. Thank
All
you.
right. Thank you. Have a good evening.